You'll start with the history, vital signs, temperature, pulse, respirations, blood pressure, SpO2. You will ask allergies, medications, tobacco or other stimulants, and alcohol. You'll begin with the shoulder. Begin with inspection. Shoulder contour.
All right. Good. I'll read all the inspection part.
Shoulder contour, bony prominences, skin and subcutaneous tissues, surrounding musculature, and glenohumeral rhythm.
Perfect. All right. What I need for you to do, sir, is go ahead and take off your shirt. While he's doing that, I'm observing his ability to take off his shirt, noting that any kind of painful motion, no issues with that? No issues? Good. All right. So first, I'm looking at the overall contour, looking at how it lies on his body configuration. So I'm not seeing it kind of rounded over, kind of nice and pulled back. I'm looking for the kind of the upper tract complex going on, seeing how the deltoid sits and looking for symmetry going on there. I'm also observing for muscle atrophy or hypertrophy going on through, so once again, can look at the deltoid structures, looking at the pec structures, the upper trunk structures as well. The bony prominence is really kind of pick up on is just the clavicular region for the anterior parts. I'm looking at the clavicle, seeing how it lies through there, looking for symmetry on both sides. Noting at the AC joint, do I see one sticking up more than the other? Could it be indicative of older AC separation or current AC separation? I'm going to have you stand up, sir, and then we're going to have you face the board. Now I'm looking at the posterior region from here, and I'm just kind of looking for the spine of the scapula. If I don't see it, then life is good, just on the symmetrical. But if I notice one spine more prominent than the other one, that would be an indication of possible atrophy going on with primarily the supraspinatus and the infraspinatus. I'm looking at the vertebral borders up into here, once again looking for symmetry, and I'm also looking at the axillary or lateral borders as well.
Palpation.
Oh, sorry. So glenohumeral rhythm. So what we're going to have you do, you're going to face away from me, but I'm going to have you do these motions. One's going to be bring it straight up like this right here, and bring it down nice and slow. The other one's going to bring it here. I want you to turn your palm up, bring it up all the way overhead, take it down nice and slow, much like that. If you can do that right over there, the way we can kind of watch you. So I'm looking at the glenoid and the humerus moving, but I'm also looking for scapular winging. So I'm seeing how well the scapula lies flat onto the back itself. I'm looking at nice smooth motion. I know that 60% of abduction comes from the humerus moving, 40% comes from the scapula moving. So I'm making sure that's all correct, and also no any kind of clunking going on. So go ahead and do that abduction again for me. So scapula does move a little bit more than others, and we agree the left side maybe a little bit more, but it doesn't look to be too significant, clinically speaking. I'm also really observing for any kind of clunking, noting it as you maybe go down the abduction, you kind of clump down, that might be some indication of instability issues. Okay, go ahead, have a seat up here.
Palpation. You'll palpate the joint spaces, the bony landmarks.
Perfect, sit there. So I'm going to start over here on the clavicle. I'm going to palpate kind of the sternoclavicular joint, kind of track it over into here, notating any tenderness, any kind of crepitus. Take it all the way over to the AC joint itself, any kind of tenderness up into there, you know, feeling on the acromion itself, and kind of going a little bit into subacromial space, a little bit ahead of myself. So the joint space you only need to focus on really is going to be the AC joint through here, and you can arguably kind of get deeper inside there if you kind of get through the pec structures into the actual glenohumeral joint, noting kind of deeper kind of shoulder tenderness and joint tenderness.
Bony landmarks. The AC, the spine of the scapula, the vertebral border of the scapula.
Good deal. So we got the AC ready. Have you stand up again and face the board. And I'm doing all this bilateral too. So in the room itself, you need to either verbalize that I'm do it bilateral and verbalize. Would you like me to continue both sides, or do you want me to just focus on both on one side and let the instructor kind of make that call? For time reasons, of course, it'd be easier to just do one side, but I need you to verbalize it. I would be doing it on both sides. So I'm going to palpate on the spine of the scapula. Once again, it's mainly for a landmark to kind of note where the supraspinatus fossa is and the infraspinatus fossa through there. I'm going to come over here to the vertebral borders, note any kind of tenderness, any issues through there. You know, now come over here to the lateral borders and note any kind of tenderness as I kind of track along through there.
You'll then palpate the muscular insertions, the supraspinatus, the infraspinatus, the long head of the bicep, the subacromial bursa, and the bicipital groove.
Perfect. So come up here. We'll do the infraspinatus more. So once again, notating where the spine of the scapula is. If I kind of track that out, that's going to take me to the kind of the posterior rim there of the acromion. And I know the infraspinatus is sitting right there inferior, so I'm going to track out through there. So the infraspinatus kind of goes there. So I'm going to notate inner tenderness to the posterior part of the acromion, and the infraspinatus kind of goes over the greater tuberosity, notating any kind of tenderness. Then I'm gonna kind of track that here on the superior part of the, or superior to the spine of the scapula, track it out. I'm gonna lose the supraspinatus in that subacromial space. That's gonna be okay, because it's gonna pick up. I'm gonna feel the cord-like structure right there in the subacromial space and notating it, whether it's tender to palpate or not. From here, I'm gonna go anterior. I'm gonna palpate right here within the bicipital groove, and I'm palpating on the long head of the bicep right here, notating any tenderness. And then last is gonna be just that subacromial space, arguably right there in the supraspinatus region, notating any kind of tenderness.
Next is
your triceps in there?
Did not say anything about triceps.
That's it.
Next is range of motion, active and passive. Flexion, extension, abduction, adduction, internal rotation, external rotation, and shoulder shrug.
Perfect. All right, so what I'm gonna have you do is you're gonna be moving them up very similar to the gluteal rhythm, bring it straight up over body for flexion, and then I'm gonna have you bring it straight back as far as you can for extension. So there's full active range of motion there compared to both sides, so I don't need to worry about passive range of motion. If there was any deficit, then I would do passive range of motion. So you can just verbalize that for flexion extension. I'm also gonna notate any kind of arc or painful arc of motion. From there, what I want you to do is just bring it out, same thing, out to your side, palm up all the way up overhead, into abduction. That's full, good. Down your side, and what I have you do is just bring the right side across body. Perfect, into adduction, and switch sides. Good. Now what I have you do is I want you to turn your hand up here, and just bring it down as far as you can on the right side. Now we're looking at external rotation itself. And I'm going to notate the spinous process is going to go down to approximately around T3 area. So we're going to switch sides. And it's roughly around the same area. So it's approximately T3 for external rotation. Now what I'm going to have you do is just the opposite. I want you to bring it up like this right here and take your thumb up as far as you can go. Now it looks like you're around that T5 area. And switch sides. And once again, we're looking at internal rotation, so about the same spinous level as T5, so you're equal on that right there. You could do it that way. If you choose to do it the old-fashioned way, you kind of bring it out like this right here to external rotation and internal rotation. That's your prerogative, but if you want to do a quick screening, do it just like I did there. Okay?
Straight.
Shoulder shrug.
Oh yeah, shoulder shrug.
So just bring it up through here as much as possible. That's it. The strength, that's good. All right, I'm not to read it. So what I'm going to have you do is face me. You can do it this way here and kind of do your speed at the same time, bring it up like this, hold it down, move you, so I'm testing out flexion, or you can kind of bring it up a little bit, bring it forward, hold it down, move you, that's flexion, kind of bring it back through here, kick it back all the way, perfect, hold there, into extension, good, bring it up through here, hold it down, move you, testing out as abductors, good, bring it into your side, going to face the, there you go, hold it down, move you, testing out as adductors, going on to there. And then what I'm going to have you do is face me again, hold it here. So I'm going to push them into internal rotation, so we use external rotators to resist, so I'm testing these external rotators, good. And then just the opposite, internal rotation. Good. Bring it up to here, hold it, don't move you. Did I take that out? Yeah. Okay. Special test?
Special test.
We'll go in order as it's written down there.
It's Nears, Hawkins, apprehension, sulcus, jerk, O'Brien, speed, Jurgensen, empty can, drop arm, and crossbody.
Perfect. All right, so the first one's going to be Nears. So what I want you to do is go ahead and turn your thumb down to the ground, just like it's right here, and go ahead and relax for me. I'm going to take the weight of your arm and move it up overhead. So I'm going to bring it up to here, nice passive range of motion. If the patient says that hurts them, I'm going to say point with one finger, what makes the Nears positive. If it's painful to the subacromial space in the supraspinatus, or it's painful in the bicipital group of bicep tendonitis. The next one I'm going to do is a general screening for impingement. It's the Hawkins. I'm going to bring him up through here at approximately 90 degrees of abduction. I'm going to hold his wrist so it doesn't flop around and just quickly kind of internally rotate him. Bring him forward here, internally rotate through here. Once again, the patient will say it's painful. I say with one finger where. They're going to point to the subacromial space for supraspinatus tendonitis or in the long head of the bicep for bicep tendonitis. There. After that, we're going to look at some instability issues. So the first test is going to be apprehension. I'm going to passively bring them up into abduction at 90 degrees. And then I'm going to externally rotate them back over here. What's going to make this test positive is the patient's going to have the sensation of it slipping at a joint. It's going to feel unstable, so they're going to tell me to stop doing that. If this person was a first time dislocated, just dislocated recently, or a chronic dislocator, then I have them lay down supine and do the same motion, but give them a little bit more stability. Now I'm gonna test for inferior instability. So I'm gonna put my hand up through here, grab onto the medial lateral epicondyles, and pull down through here, and I'm noting any kind of inferior translation, and I'm looking for the sulcus on the subacromial space. The last one I'm gonna be looking for instability is gonna be posterior instability. I'm gonna face forward. So I'm gonna bring them up here into abduction, or flexion, and now I'm gonna attempt to kind of axial load going posterior, but I'm gonna stabilize the scapula back here so they don't rotate through here. I'm gonna put some weight behind it and push back posteriorly, and I'm noting any kind of posterior translation or kind of clunking when I do that. What was after that?
O'Brien's.
O'Brien's. So if you came back and had some kind of dislocation, some kind of internal derangement, and talking about pain within the joint itself, I'm worried about a slap lesion, so superior labral to anterior posterior tear. I'm gonna bring them up. I'm gonna bring a cross body through there. Thumb's gonna be down. I want you to hold it there, don't move you. I'm gonna attempt to push him down. With the thumb down, he's gonna complain about pain. Ow, that hurts. Thumb up. Hold it, don't move you. And now that doesn't hurt, or is there a considerable decrease in pain going over there? So thumb down, bad. Thumb up, not so bad. That's gonna be a positive O'Brien. Once again, no slap lesion.
Next is speeds.
Speed test, now I'm worried about the bicep tendon in this pathology, so go ahead and face me. I want you to bring it up like this right here. You can go and straighten out your elbows ever so slightly. Hold it there, don't move you. I'm attempting to push him down. If he complains about pain, with one finger where, and what's gonna make it positive, if it's a pain focal right in the bicep group. After that, we're gonna go now to the Jorgensen. So what I'm gonna have you do is bring your arm up through here, much like this right here, and I'm gonna give you some slight resistance down, and then what I want you to do is allow me to move your arm in and out, so into internal and external rotation. And I'm gonna stabilize the elbow ever so slightly. You can do it here, or if you wanna hold it here, that's fine, just as long as you don't put too much pressure in the bicep or the groove. So give me a little pressure here, internal and external rotation, good. And it's gonna say, ow, that hurts. It's gonna point to the bicep or groove if it's painful. But the other thing that I'm looking out for is whether the bicep tendon is subluxing out of the bicep or groove. So positive Jorgensen would be bicep tendon and or subluxing bicep tendon. Empty can.
Empty can.
So I'm gonna bring it up through here, thumbs down, and I'm gonna bring it ever so slightly forward. Do that for me now. I'm going forward into the plane of the scapula. I'm going to push down. Say, ow, that hurts. I know with one finger where. He's going to point to the subacromial space through here to make it positive. From there, if I'm worried about the integrity of the whole supraspinatus, what I'm going to have him do is bring it up to the side into abduction. If he was not able to do that, then I would be concerned about the supraspinatus being gone. But if he was being able to, he was compensating somewhat, he's going to slowly drop his arm down. And as he's doing it, I'm going to kind of give him pressure, slowly drop it down. More pressure, keep going. Keep going. Keep going. Good. And somewhere around that 10 to 15 degrees of abduction, that's when, as soon as I give resistance, your arm's going to drop down. We'll call that a positive drop arm test. And once again, I'm worried about the supraspinatus being ruptured.
Cross body.
Cross body. Now I'm testing for AC arthrosis, so acromioclavicular arthrosis. I'm going to bring your arm cross body through here. I would say the majority of the time, this is going to be enough to elicit pain at the AC joint. But to make it worse, what I'm going to do is put my hand across through here. And then they're going to attempt to do horizontal abduction, and I'm going to resist against them. So pushing my hand. Good. As soon as I do that, I'm loading the AC joint. They're going to talk about pain, and to make it positive, it's going to be right there at the AC joint.
Elbow and forearm. Inspection, elbow contour, carrying angle, skin and subcutaneous tissue, surrounding musculature.